because probably sex steroids have modulatory effects on the immune system and predominantly on the lymphocyte differentiation, and hence these autoimmune disorders tend to be more common in female as compared to males. And these effects of thyroid dysfunction, may it be hypo or hyperthyroidism, are manifold, and they may complicate surgical procedures and post-operative recovery, and hence recognition, diagnosis and optimization of pre-existing thyroid conditions in patients who undergo surgery is very important. So as far as the recommendations for pre-operative screening is concerned, routine testing of thyroid function, unfortunately is not recommended, and TSH testing should be done in cases where there is a clinical suspicion of thyroid dysfunction, may it be hyper or hypothyroidism, and if the patient is already a known case of thyroid disease, in such scenario, a TSH should be checked. When central hypothyroidism is suspected, that is when the hypothyroidism is at the level of pituitary, then both the serum TSH as well as the free T4 should be tested. It is important to note if the patient is already taking levothyroxine, then the sample should be taken before the patient has taken the pill for that day. Now coming to the systemic effects of hyperthyroidism, so we'll be predominantly discussing the cardiovascular. Patients may have tachycardia, angina, atrial fibrillation, hyperdynamic circulation in the form of increased cardiac output. They are more prone to heart failure. They may have pulmonary hypertension, because these are because of the genomic as well as the non-genomic actions, predominantly T3 that happen on the myocardium, and these T3 is responsible for both the systolic contractility as well as the diastolic relaxation, and it also has effects on the AV as well as the SA node, and hence right from the contractility to the polarization pathway, the T3 has a role throughout the pumping system of the heart. There are also respiratory effects where there is an increase in the ventilatory drive. Patients may have respiratory muscle weakness and again pulmonary hypertension. And we are doing all this because there is a condition which is known as thyroid storm, which is the biggest concern during the perioperative period, and it is basically characterized by tachycardia, confusion, fever, gastrointestinal complaints, and potential to cause a cardiovascular collapse. Now just a few short studies to tell us why these things are important. So this was one of the study by Brent and colleagues, which showed that this meta-analysis showed that the overall mortality in patients with hyperthyroidism was 21% greater as compared to general population. So this is frank hypothyroidism. T4 are within the normal range. So this meta-analysis, which was conducted by Yang et al. Done in China, it showed that even in patients with subclinical hyperthyroidism, there was a 19% risk of cardiovascular disease, 52% risk of CV mortality, and 25% risk of CV morbidity. Coming to patients who have thyroid in the perioperative period, and why do we need to treat it efficiently? So this was a study which was done by Johann. So there was almost a 23% increase in the risk of mortality in the patients who were not adequately controlled, and hence this becomes very important. So because of this, elective surgeries should always be postponed in patients who have overt hyperthyroidism. However, in patients with mild or subclinical disease, a preoperative beta blockade is considered to be sufficient. In such scenario where emergency surgery has to be done, the cardiac status must be closely monitored, and perioperative placement of an arterial line or a central venous pressure monitor is appropriate if the patient has a cardiopulmonary disease. Now coming to the different molecules that we have that should be used during the perioperative period. So this was, although this is, this is a landmark study because this is probably the first study which basically, proved the role of beta blockers in the perioperative period as far as management of hyperthyroidism is concerned. So this was a very old study, 1987, but the first study which showed its benefits. And this was, basically beta blockers were given in hyperthyroid patients who were undergoing thyroidectomy, and one group was just given 5 weeks of metoprolol versus the other group that was given 12 weeks of combination of methimazole and levothyroxine. And what they found out was there was no serious intra or post-operative complication in the metoprolol group. So in spite of receiving, the methimazole and so block and replace for 3 months, even, beta blockers did equally well as far as preventing post-operative complications were concerned. And there are multiple studies which show that there is no significant, benefit of one beta blocker over the other. However, atenolol may be, preferred in some cases because its long half-life facilitates once daily dosing. But however, because the metabolism of the molecule itself increases, the total daily dose may still be given twice a day. Propranolol can also be used, but it requires multiple daily dosing. But it also has, additional benefits because it prevents the conversion of T4 to T3 in the periphery. And as we discussed, that the T3 is the predominant molecule which has its effects on the cardiac myocardium. And propranolol can also be used intravenously to control blood pressure and even control the pulse rate. Calcium channel blockers can also be used in patients who do not tolerate beta blockers, and these drugs should be used so as to achieve a heart rate of less than 80 per minute. Because both beta blockers and CCBs decrease sympathetic activity, reserpine or guanethidine may be considered for those in whom beta blockers and calcium channel blockers are contraindicated. So beta blockers followed by calcium channel blockers and followed by reserpine and guanethidine in that order. Now coming to the role of antithyroid drugs. So antithyroid drugs, predominantly the thionamides, they should be used in patients where thyrotoxicosis is due to increased thyroid hormone production. So that is, predominantly in patients with Graves' disease or patients with toxic thyroid nodule. These drugs should be started as soon as possible, especially, patients who plan for surgery, because the effects of these drugs may not be apparent for several days. Methimazole may achieve a euthyroid set faster than propyl thiouracil, but it may still take 3 to 8 weeks. So methimazole may take around 3 to 8 weeks, and the same for propyl thiouracil may range between 10 to 12 weeks. Methimazole is probably preferred because of its decreased potential for hepatotoxicity and its longer half-life, which facilitates once daily or twice daily dosing. Propyl thiouracil, because it has a short half-life, needs to be administered every 6 to 8 hours. Again, concomitant use of beta blockers and thioronamide should be, more or less adequate for majority of the patients who are planned for surgery. And these agents should be continued throughout the post-operative period to prevent a thyroid storm, and possibly longer unless the patient is treated for thyroid resection or iodine 131 ablation and is no longer hyperthyroid. In patients who undergo thyroidectomy, thioronamide should be stopped post-operatively. However, because the half-life of levothyroxine is long, it may still be necessary to continue beta blockers for about a week after thyroidectomy. The other molecule which is used or less commonly used is lithium. Lithium decreases the thyroid hormone release from the thyroid hormone, but it is usually avoided due to its systemic effects. However, if it needs to be used, it is used between the dose of 600 to 1000 milligram and starting at 300 milligram every 8th hourly. Another very important molecule, that is iodine. So inorganic iodide should be given as an adjunct to thioronamides. What the iodides do is that they inhibit the organification and oxidation of the thyroid and decrease the thyroid hormone synthesis by the Wolff-Chaikoff effect. However, this may take around 24 hours. However, in patients who have toxic thyroid nodules, it is very important that you start the thionamides first and then administer iodine. However, this effect is transient, and because of the down regulation of the sodium iodide importer, after 10 days, the patient will experience an escape from Wolff-Chaikoff phenomenon, and hence iodine should not be started for more than 10 days prior to surgery. So these are the options that we have. As far as the most commonly used is Lugol's iodine, the dose of which is around 3 to 5 drops 3 times a day, and a rarely supersaturated solution of potassium iodide where the dose is 1 drop thrice daily. Glucocorticoids also inhibit the peripheral conversion of T4 to T3. They may be added pre-operatively and tapered 3 days post-operatively. These are the suggested regimens: hydrocortisone 100 mg IV 8 hourly, or a dexamethasone dose of 2 mg every 6 hourly. Or rarely, betamethasone can also be used. Cholestyramine not very frequently used, but they decrease the circulating hormone levels by binding the thyroid hormones within the intestine and decreasing its absorption. If to be used at a dose of 4 grams 4 times daily. So, concluding, when you have thyrotoxicosis due to exogenous hormone intake, there is no role of antithyroid hormones. Beta blockers and calcium channel blockers can be used. In patients with thyroiditis, again, antithyroid drugs don't have a role. NSAIDs, play an important role along with the beta blockers. And for all patients with thyrotoxic, irrespective of the cause, corticosteroids, iopanoic acid, and cholestyramine may be considered. So, hyperthyroidism, if subclinical, preoperative beta blockade is enough and you can proceed with surgery. In overt hyperthyroidism, if it is an elective surgery, treat with antithyroid drugs, beta blockers, and wait for surgery till the patient is euthyroid. In emergent surgery, treat with antithyroid drugs, beta blockers, iodine, glucocorticoids, cholestyramine, and proceed with surgery. So this is a short flow chart representing the same. And I thank you for your patient listening.